Hello everyone and welcome to this webinar on Focus, Shockwave and Diagnostic Ultrasound, how to make these a success in your private practice. For those of you who have not come across PhysiQuip before, a little introduction. My name is Dominic Smith. I'm the Clinical Application Specialist at PhysiQuip. As the company generally, we focus on MSK rehabilitation and in building great relationships with our clients to challenge and improve the standards of care and clinical outcomes for you and your patients. And we do that through medical technology and education. Obviously, part of the education tonight, you're a part of our PhysiQuip Academy, and thank you very much for joining us this evening. We're joined by Jeff Twinning of the Five Valleys Physiotherapy, who will deliver a presentation, and then we'll follow that up with some Q&A. We have got some brilliant pre-submitted questions already, and we will go through some of these. But if you do have any questions yourself, you've got a question function at the bottom of the screen. Pop it in there, and we'll see if we can get through to them. But anybody watching online, watching the recording, if you've got any questions you'd like to submit, just email it to us, and we'll get that answered. All the details will be at the end of the webinar. On that note, Jeff, I will hand over to you, and you can get into your presentation.
Lovely. Cheers, Dom. Thanks, guys, for coming. So yeah, as Dom said, we're going to be looking at how to incorporate Focus, Shockwave and Diagnostic Ultrasound into your private practice. And this is very much about not so much the principles of using it, but how to financially make it work, or at least to start looking at how you can make it work. So this is a few of my team, and this was when Dom kindly sold us a couple of lovely units. So I'm a bit about me. I'm a chartered physio, 20 years in practice, a big history in elite sport, so Olympic Games, Commonwealth Games, Team England athletics, hockey. I've done most things, and I suppose my passion is trying to excel myself beyond the average. That's kind of what I always look at with my business and the people around us. And with scanning and the shockwave that we've got, and we'll come on to the type of shockwave, this is how we kind of stand our clinics above everybody else in our county of Gloucestershire. So I initially started with Five Valleys Physio as a work experience student, and then had the opportunity to work there as an associate, and it was a small tiny clinic, 2 rooms. Then I left the NHS, worked there a bit more, and then became a partner. And then slowly I've just kind of taken out the retiring partners and expanded the clinic, which I think is now probably 5-6-fold what it was when I first joined. And now we have a clinic in Stroud and a clinic in Gloucester. And we have a team of around 20 in Stroud and a team of 10 in Gloucester. So Gloucester's kind of a newer development that we're trying to pitch it the same as our Stroud clinic, which is quite large. So a big part of why we do this is, for me, it's about accuracy. It's about being very pinpoint in our diagnosis, and then also trying to provide that gold standard treatment approach. And that's where the Focus Shockwave comes in for this portion. So what we're going to do today is we're going to discuss how to incorporate both of these products. Do you need both? Can you operate with one? The investment of both and the reward potentially. And then obviously we're all clinically driven. So providing clinical excellence is my passion. So the business questions, why would I want to spend, potentially a significant amount of money on a major asset? What is the return on that investment? So you'll repeatedly hear me talk about ROI, so return of investment. What is the risk? How are we going to fund it? Not everyone has liquid cash to spend, so are there other options? And what is the benefit to the clinic, the client, and the staff that you have, whether that's just yourself or whether that's a team? Now, I'm going to look at this in 2 parts. One is looking at the diagnostic ultrasound, and the second is looking at the shockwave relatively separately, so that it's not just a merger, and that way you can hopefully take away some more salient points about each and then utilize both of those. So for me, diagnostic ultrasound is about providing an accurate diagnostic. And when we compare that to non-diagnostic scanning and providing that, there is always a question mark about accuracy. And the only way you know if you're accurate is if, does that patient get better? Is that patient someone who isn't getting better or isn't making full resolution? And that's where I think where we scan straight away, we dilute all of that, or we concentrate those who get better first instance. So when we look at accuracy, the things we're going to look at is the injury sites, the severity of the injury, so whether that's a grading system that you can standardize, the pathology going on, so recognizing different types of pathology in the same tissue type, whether we're looking at a chronic or an acute timeline of healing, because again, that will dictate how we treat it, load it. A big thing which you can't see without scanning is neovascularization. So if you have a chronic tendon, over time and with chronic pain, that can start to generate a new blood supply. And we know from the research that more blood supply equals more sensory input, equals more pain. And those patient groups potentially are a little bit harder to get better. Doesn't mean you can't, but you can then appreciate that actually this may take 6 months, not 3 months. So again, from the very offset, you'll be able to inform that patient and get their expectation correct. The other is differential diagnosis. So, you know, if you're looking at an Achilles, I'll call it an Achilles area, then you're looking at the retrocalcaneal bursa versus the Achilles tendon versus the paratendon versus flexor hallucis versus the peroneal tendon. So straight away, there's lots of structures there that you can go, looks normal, and this area appears abnormal, and why that is. Now, that doesn't mean that's the pain source, and that's really important. But what it does do is give you a very strong starting point. I personally find I don't refer for MRI so much now, because we know that diagnostic ultrasound can be more sensitive for certain things. So rotator cuff tendons, Achilles, fantastic, stress fractures in certain areas, other areas, MRI would be gold. So for me, for the client's perspective, it's cheaper. I'm not sending people away that need an orthopedic review first before MRI, or if we're quite lucky in our area because we have a charity funded MRI unit. So MRIs cost about $250 rather than, you know, an excessive amount more. So we can offer a service that's cheaper than that. And also we can repeat that ultrasound. So if we want to check healing, or we want to check a more for personal gain, long-term outcome. So if someone comes in and says, I'm pain-free, we can rescan that tendon or that area and actually disseminate whether or not clinically they are perfect, or whether just from a pain perspective, they've improved. So that list is a brief list, but are the kind of main points that really give you the advantage with scanning. So looking a little bit more into scanning, what are we looking at? So we're looking at the fibrillar pattern. So that's whether that's of a muscle, a tendon, a ligament, whether it's a normal fibrillar pattern, whether it's altered, whether it's interrupted through some sort of lesion. We can look at the synovial reactivity. So a classic of that is like de Quervain's, where the paratenon is actively inflamed, but the tendon is completely normal. And you may see some reactivity around joints as well. One thing that I scan a lot more now is joint margin, especially of knees, the smaller joints as well. But for me, knees, it does give quite heavy evidence. And you can look at joint space, you can look at, you know, the edges of the meniscus, you can obviously look at all the ligaments as well. And another really important part of that scanning is, especially again within a knee, is there a joint effusion? Again, it may not be the cause of pain, but it gives you a lot of evidence that it's an intra-articular problem. The level of the effusion gives you an idea of the severity, and you're hanging all these factors of scanning onto your clinical testing. The other fantastic thing with diagnostic ultrasound is that you can dynamically test certain structures. So if you have, let's say, a shoulder impingement, with a movement, we can test the bursa, we can test the rotator cuff, we can test whether the long-headed biceps tendon is subluxing, whether the AC joint is unstable because of chronic degeneration, and we can also test ligament stability, whether that's of an elbow, a knee, you know, a nice hinge joint where we can load it and does it gap. And that again is really good for testing pain response, but also integrity of the joints. Now, one of the big things we scan are tendons. Now, whether that's your Achilles, whether that's your extensor carpi realis brevis for your assumed tennis elbow. And again, when you're looking at a tendinopathy, I think it's really important to put a degree of severity. And I always use the 1 or the 0 to 10 scale of 0 normal, 10 being severe. So patients know where they're at. And then obviously from that, we can determine a relative time period for recovery and loading. The location of the tendinopathy is important. Again, looking at an Achilles, it's not always the whole Achilles that's affected. Sometimes it's the anterior portion, sometimes it's central. And that, again, is really significant information. We discussed the neovascularization before. And touching on bone injuries, stress response, stress fractures, ultrasound has been shown to have a high sensitivity. Again, personally, I find if I send someone off for an MRI, which I never do with a stress fracture, the number of people who come back reported no stress fracture, no stress response, but they clearly have symptoms. I scan them and you can see bone edema, you can see small cortical changes, and that has to work alongside bony tenderness. So again, with scanning, you can palpate at the same time to give yourself very strong information about what's going on. So things to consider. So that's a brief overview of why we scan, all about accuracy, all about diagnostics. And this is a little bit about, if you're thinking of that, you know, your game that you want to look at, things to consider when you're investing. So diagnostic ultrasound isn't a cheap process. You've got the training, and that's not a 1 course, 2 course, 3 course process. That is ultimately a year-on-year development of skill set. And within that training, you have to be able to prove competency. And within competency, the better you are, the more proficient you are. So those are really important terms with any sort of out of normal practice processes that you're doing, whether that's injections, scanning, or whatever else. So competency is really key. And when I started scanning, I did a weekend course, and then I did an intermediate course, and then I did an advanced course, and then I did a mentorship program, and then I've done a PGC, and then I've gone back again and looked at things. So that process is a long one, but like being a therapist, whether you're physio, chiro, osteo, you know, the longer you do it for, the better you become at it and the more proficient you become at it. So when you're looking at your training, you can obviously do a postgraduate certificate. And there's some new documents that have been released by the CSP at the moment, looking at point of contact ultrasound, which is ultimately what we're doing as physiotherapists. And that any PG cert needs to be case accredited, and they are the governing body that our framework needs to fit into. So it's a standard of training. You've got weekend courses, and as you can see, you know, dotted around that slide there, Sports Medicine Ultrasound Group were my provider. So I've done course with them over the last 8 to 10 years. There are others out there, but my preference, based on physios running the course who have been where you will be, they're my go-to. There are a couple of others around. Again, some are physios, some are not. So it's always worth looking at what works for you in your framework. The machine cost is obviously a biggie. For me, there's no point in doing a course if you don't have a scanner, because you're not going to be able to practice, and you know, whatever you do on the course, you won't be able to implement back in clinic. So that's an important thing to bear in mind. So this is a all or nothing approach really to scanning. You know, you're either prepared to go in, you know, knee high, but if you tickle the outlines, you won't really benefit. And then it's really important to have a mentor. So someone who's either done it, someone who maybe could just be a radiographer, who's willing to give up some time, whether that's paid or not, and that's another matter to think about, who you can go and shadow, or they can shadow you, so you can get some feedback actively once you're doing it. Some people take to scanning, some people don't, and it's very much down to that hand-eye coordination, you know, being able to scan but not look at your hand, and be able to look in a different direction at the image on the screen. And so this for me was where PhysiQuip came in. So I looked at various companies, what they had to offer, how good was their support around that product, how good were they at selling their product, so you know, what was their unique selling points, and if that didn't come across very well, they were in a draw, and I moved on. And PhysiQuip were fantastic at that point. So there's many machines, price points really probably going from 5,000 upwards to significantly more. There's a lot of reviews on some of the newer, what I call entry-level scanners, where maybe you've got you can put it on your phone with a handheld device. Again, I think you're only as good as your machine, so sometimes it's worth paying a bit more, getting an intermediate level machine, than something that you're just going to want to upgrade in a year. So although that outset may be cheaper on the initially, if you then getting rid of that and get a new product, then you're paying twice. Fab, so that's your competency, machines-ish, and potential courses. There aren't many courses, I've got to say. So I know UEL do a PG cert, possibly Coventry. There's a few dotted around. I wouldn't say they are on the mass market, so which in a way is good, because the people running them are generally market leaders. So when we talk about the business model, I think everyone will have a different principle. As I was discussing with Dom before this started, I'm a maths man. You know, it's black and white, money in, money out, in whatever form of business you're in, is very simple. And I think simple is good. I always go off the algorithm of KISS, keep it simple, stupid. If you do that, you can rarely go wrong. And obviously within those things, there's risk, and that's another kind of extraneous factor that you need to consider. But for me, it was all about, what does a machine cost? What does it cost to train? And that will give you an expenditure figure on average. And then what can you charge for that service? But again, you can only charge if you're competent and proficient, because once you start to charge, you have a duty of care, you have that ability to report right. And if that ever came back as wrong or negligent, they will look at, are you competent and are you proficient? So it keeps coming back in full cycle. I didn't charge for scanning for probably 8 years. I used it to complement my physio, which again gave me a heads up over the next physio. But I didn't feel I could charge until I had an academic basis behind it, even if it meant it didn't make me a better sonographer, but it meant I could hang my hat on the fact that I've got an academic qualification to support my findings. So what you can charge, well, go back a level. I think when you're looking at, if you're using scanning, whether you charge or not, there is still value. You know, there's a value if I'm going to see that person over that person because they can scan, it doesn't cost me anymore, and they're going to give me a better service. So there's an inherent driver there. More people seeing you, more revenue, versus I'm charging for scanning and I'm getting an additional price on top of my standard fee or my standard consultation cost. So you can roughly figure out then, you know, how many scans a week do I think is relevant? And and how many scans, say 5, how much extra is that going to give me per week, per month, per year? And that's going to enable you to work out then roughly how many scans is it going to take to pay off that machine. Other non-direct profit benefits, like I just said, may just be you see more people. So it's not a direct revenue increase because of you're charging more, but you're seeing more people because you have a skill set that maybe no one else has in your area. As far as I'm concerned, I am the one of 2, if not the only physio in Gloucestershire who scans to the level that I scan at a competent report MSK sonographer level. So that gives me a huge USP over anyone else, which is a good thing to have. And then I put this question at the bottom: does it need to be profitable? So when I started scanning, actually, it wasn't because it was going to make me more money. It was because it was going to make me a better physician, more accurate, better at differential diagnosing. And then with time and competency again and better machines, I'm now delivering a service that is, hopefully, as Don will agree from when he's seen it, I've got a machine that is radiographic level. So when people come in, it fits the bill. Their expectation then is, whoa, this looks good. And the buy-in and everything goes hand in hand. And I don't charge a ridiculous amount of money either. So, I would prefer people of volume use it than charge too high. And then I have less people wanting scans. And actually, I've got a service that has been underutilized. So unique selling points, keep that in mind. So the business questions, again, we've done all these. Why? Want, major asset. You might have money in the bank that you need to burn because otherwise you're going to have to pay 40% tax on it or 20% tax on it. Always look at your return on investment. The risk for me is always about what does it cost and when am I going to get my money back? Very, very simple. And that is the same for anything from a business perspective. Is it going to take 6 months, a year, 2 years, 3 years? If in 3 years, you may need to upgrade your machine. So again, there's an outlay again. You think you've just broken even and suddenly there's another expenditure coming up. So for me, I'm looking 6 to 12 months for any investment. I want that money back to pay for the machine. And then I know anything on top of that is profit, which may then fund a better machine, and that snowball develops. And you can fund it through different ways. I mean, rule number 1 in business for me is never use your own money. And some may laugh at that, but I think it's, keep liquid cash in case you need it for whatever purpose. It may be you part pay. It may be you use any adjacent loan companies, or you get a personal loan out, or you get a business loan out, which I always find if you can overpay it, you've got flexibility. So if it's doing really well, you can chunk it off and you can get rid of the term very quickly. But on the same hand, if you're having a quiet period, or maybe it's just a demographic of patients coming through the door, you're keeping your monthly costs quite low. No different to your mortgage. If you can overpay, get it gone quicker. But especially with COVID, if you can keep it at a level that where income is lower, it's not going to be devastating. And when we talk about the benefits of the clinic, again, it's always about USP. How is that going to drive your clinic above the rest? How do you compete with others? And again, for me, it's always about what can I offer more than Dave down the road, or what can I offer far better than another professional, whether that be physio, chiro, osteo, or sports therapist. And that's always in my mind, day in, day out, and I constantly review the competition, see what they're promoting, see what they've got, because I think it's important to know your competition and what you're up against. Know your enemy. So there is some, not controversy, but probably lack of knowledge. When we look at Shockwave in itself, you have radial and you have focused, and they are completely different, although very much labeled as the same. Those who have radial will push it. I've got Shockwave, it's amazing. I've got a focused machine, and the reason I went with focused is because I want the best product available to deliver the best service that I can give to patients. I think also the research that is out there, because I'll put it in commas, but Shockwave is NICE approved, you know, which is a high level of evidence to suggest that it will work for certain problems that you'll see. And I think radial is a completely different mechanism of delivery, and it has a completely different physiological effect compared to focused. But unfortunately, it's labeled the same. So you might have a machine at focus that is and potentially 4 or 5 times more effective than radial, but it's still umbrellaed at the same, especially when you're talking to likes of Bupa, AXA, who will actively fund this. So as a revenue generation, if you've got a patient who's, say, with Bupa and you're seeing them for an Achilles, you can, alongside your physio provision and costings, get a separate authorization for focused Shockwave or radial, again, canopied the same, and deliver 2 treatment packages. One is your physiotherapy or chiropractic osteo, alongside your Shockwave. So that's probably another webinar, which again we'll touch on with Dom. But radial and focus, there will be questions about why should I get one over the other? Could I get both? And what's the benefit and what's the reason behind that? So moving on to your Shockwave therapy. For me, I think we've been quite lucky because we've got, I think, a team of 16 therapists now in clinic. So we've got more people exposed to it as a treatment modality. They don't make any more money using it because we've invested heavily and we've said, look, this is a great product. This is why we use it. But we need to pay the machine off first. If you want to provide a better service, if you want to get patients quicker, faster, this machine will help you alongside your therapeutic processes. It doesn't replace it. You know, we're very hands-on. We're all about soft tissue correction. We're all about normality of joint range and function. But the key factor with all of this is, especially when we talk about tendons and joints, it's all about loading. So even with the best Shockwave in the world, you need to load that tendon appropriately. And a lot of people don't load heavy enough, and that's why people don't get better. So getting the team on board will improve your ability to expose more clients to the service. That will in turn increase your sales. So we sell it as a package of 4, with then an add-on if they need more, but typically 4 to 6 for most problems. If someone's had 6 and no better, I would question the delivery. I would then question the accuracy of the diagnostic. And 9 out of 10 times, one of those is off. So making sure your staff are trained appropriately. If you do have scanning available, I try and make sure anyone undergoing Shockwave is scanned first, so we know, again, accuracy of diagnostics. Because if I'm selling someone a package of £200 or £300, I want to guarantee them that they're going to get better. Because if they don't, what was positive PR is now negative PR. And you've lost all those referrals from that one person. And also a disgruntled patient as well, I would say. So the larger your team, the potential for a better return on your investment. That doesn't mean if you're a single sole practitioner, it's not usable, because you will drive that yourself. And even with a big team, people drop off. You know, they forget about it. If it's not there in their face all the time, it's not something they always use. So even with a big team, you've got to constantly, not push it that you have to use it, but these are the benefits. This is the education. It's constant training, having a banner in your reception area, the number of people who ask then about that, having it on your website, lots of things you can do to get that fish hook. We offer a free session. So for all of our team, if we think it's an appropriate thing and we've done our initial therapy and we think it's appropriate, then we offer a free session to that patient. And we say, right, well, if it's something you're keen to try, let's do a session and let's see the effect. Because 9 out of 10 times with the focus shockwave, it's an immediate improvement in pain reduction. The number of Achilles I've come in, 7 out of 10 pain. You do your bits, you know, they've already seen 3 other therapists, and you're like, well, your calf's mobile. Yes, I've scanned it. You've got a tendinopathy. And with scanning, again, you know the depth of the target tissue. You can apply that with the focus shockwave really accurately. And they walk out with a 1 or 2, sometimes a 0. And then always telling them, you know, after 40 hours, this will probably drop off and go back to how it was. And then that's when, you know, if they get that immediate improvement, that's the fish hook. And they're like, yes, let's do it. So it's how you sell that to the patient. It's not, we're never pushy with it. We just give them the options. This is what we can do. If you don't want shockwave, this might take 6 or 7 physio sessions to get a reactive tendon unreactive so we can load it. But with shockwave, we might find after 3 or 4 sessions, we're getting to the same point quicker, faster, and ultimately cheaper. So although there's an initial cost, actually, when you look at how many sessions you may need, it's not excessive. And client education, you know, what should they expect? So can you use it without ultrasound? Absolutely. But would you be better with ultrasound? Absolutely. So although it's not needed and you'll get good results, you will probably get the odd patient who doesn't improve as much as you want them to or expect them to. And after 4 or 5 sessions, and you may have even chucked in a freebie for 6 because you just want to get them better, they may still be lingering on that, you know, 60% better, I just can't get rid of it. And that may just be a very simple thing of depth. It may be a simple thing of, you know, there's more degeneration than you think. There may be neovascularization. There's a few other factors there that you just don't know without scanning. So you can use it, and I would probably say you'll be 70% as effective as someone who is scanning, but you're still going to get great results, far more than someone who doesn't have it. So yes, diagnostic ultrasound is a massive plus, isn't necessarily needed. But if you're looking for that, what is the pinnacle of what I can provide, both of those would sit on that for me. But you'll have a great service with one or the other anyway. And there's lots of other, you know, technology out there, laser and all these other bits, but I do worry that therapists might get lazy. So keep hands-on for me. I'm a very hands-on therapist. If someone spouts research about manual therapy, they're probably not great private practitioners. They probably don't have a great business model in that respect, because, you know, if you're not treating people, they're not in your clinic, they're not earning you money, and ultimately, you know, don't be shy to say that this is a business. I want to generate income. You know, you're not looking to be a millionaire, but it's a business, and if you're not driven by making that a profitable business, then it probably won't be a successful business or something that you can expand and develop and attract staff. It might be great for yourself in your back shed. Okay, so again, it's exactly the same business model as with the ultrasound. What's the cost? What's the training cost? Which again, with PhysiQuip, we had no training cost. Dom came in, spent the morning with us. We lined up a few patients who were in active treatment, and we said, look, you know, do you want to be guinea pigs? You're going to get a free session. Probably guarantee you're going to walk out better. So we had some live patients that we used as part of our training, and that worked really well, because again, it's, you know, some of these, especially the one I've got, you can see in the picture, it's, you know, you need both hands to hold it. They're quite heavy, and when they cost a significant amount of money, you don't drop them, because you'll be a poor physio very quickly. So using live patients was a great way of getting Dom involved. You know, what are you feeling? Because this is all about patient feedback. You know, if they're not feeling anything, you're not on the target tissue, or you're not where you need to be to get the response to make it better. So Shockwave is also a great diagnostic tool. take a knee, for example, you think you've got someone with a patella issue, and you put the shockwave on it and you angle it and they get no pain response, but then you angle it towards the femoral condyle and they're like, whoa, then actually it can massively change your approach to how you treat people. So we're using it also now on knees, degenerative meniscus, femoral condyle, chondral issues, where normally you think it's just the back of the patella that's the problem, but actually it's the condyle as well. We tend to use some of it on the soft tissue in and around the area you're treating as well. So as much as some of that evidence is more sparse, you know, a lot of these newer products, you need to look at anecdotal, you know, how is it affecting your client demographic? Because as much as evidence is fantastic and we're all driven by evidence, newer technology does not become NICE approved until you have high volume of patients being used. So for the scanning, I mean, Shockwave is already there, which is fantastic. So there is no question, you know, it does treat patella tendinopathy. It does treat Achilles tendinopathy. It does treat rotator cuff, more so calcific tendinopathy. So that research is there, it's valid, it's unarguable, it does work. The income from the shockwave is immediate, which is a bit different to the diagnostic ultrasound. So as soon as you're using this, you've got to decide what is your model, how much are you going to charge? You know, is there competition in the area? Are you the only one delivering it? And then how would you get that out there to your clients and your staff? For focus shockwave, you know, in some places they charge 120, 150 pounds a session. For me, I felt I wouldn't get buy-in at that level. So we've gone cheaper because again, for me, it's about volume. The more you sell, the more you make, the more it pays off the machine. If you price it too high, you know, if you get one a week, it's going to take you forever. So price point is important. And everyone's going to be different on that price point based on where you live, what you charge already as physios or therapists. How do you sell it? Do you sell it as individuals or do you sell it as a package to get buy-in? We do it as a package. And that includes the treatment cost or the consultation and the use of the shockwave. And we make that very explicit that they're paying a bolt-on for the shockwave, but they're also paying for the therapist's time to deliver that. Again, how many of those products do you need to sell? And then again, the other non-direct profit benefits. So people coming to you for physio because you know you've got shockwave, consultants knowing you've got shockwave, and a lot of orthopedics will know the evidence, and they'll be keen. If you've got someone who's a non-surgical candidate, they'll be keen to, you know, deliver these patients to your door and say, look, you know, grotty Achilles, have a scan if you can, shockwave, because we know the evidence is we can get people better. And this is the question that is probably a little bit different to the ultrasound, is does it need to be profitable? I think in this case, yes, because otherwise what's the point in having it? Why throw 10, 20, 30 grand down the pipe if you're not going to get something back from it, unless you can afford to do that? I certainly can't. So for me, the focus shockwave was about the product. Will it benefit my clients? And can I add another revenue stream into the clinic? And also for staff attraction, you know, as we all know, getting good staff in the current climate is very difficult. So as a clinician in your clinic, how do you attract those staff? Well, you do it by having great facilities, by having a great team ethos, by having good leadership, and by having fantastic products like we've got in the clinic. So coming to the end, which I all love, why did I use PhysiQuip? So price point is important. I did my research, I did my haggling, I battled them off against one another. And the good thing that is, you know, it's got to work for both parties. Whether you buy a house, a car, a product, you know, you want to feel that you've got a good deal. They want to feel that they've got a good deal, and that way it benefits everybody. But their prices are fair. You know, they're on point from the start. And when you look at what's alternatively out there, there's not a lot of competition. There's a lot of other units from other suppliers. Names I'll leave out, but not for anything negative. But a lot of those come with additional costs. So whether that's training costs, whether that's serviceability that needs to be frequent. The benefit of the one that we've got, the piezo wave, is there is no additional servicing required. It has much higher shock delivery before the unit needs replacing than other products, significantly more. So again, you've got more longevity in the machine to generate income. Some of the other machines that I looked at, you know, it was maybe 1 million shocks, which sounds a lot, but actually isn't that much. And then you've got to buy a new head, or you've got to buy a new, you know, part for the machine, or you need a new machine. So always look at additional costs. What is the cost to get this up and running as an initial buy, but also going through those first year or two. Again, PhysiQuip, there were no initial costs, which was great. The team support's fantastic. I can ring them up, I can pester Dom, I've got his mobile, and they've been great. You know, if we've had an issue, we've done some online training, because once you use it, and you know, you might ask questions that you didn't know at the start, you might actually find that your delivery mechanism needs to change because people are maybe reacting too much. So we've certainly done that. We've dropped the shocks that we've used. Again, done our own research and blended that in as well. But using their knowledge base to look at other areas that maybe not on your radar initially. They've got lots of in-house training as of today. You know, we've got this as well, but on their website, there's lots of webinars and lots of training packages to support you. All the team are fantastic, lovely bunch. And again, for me, the machine quality is on point. So, you know, it looks professional. Some of the other machines out there, if I'm honest, do look a bit 90s. They're a bit boxy. They're, you know, like the old pulse shockwave units. So you want something that's going to reflect what you're selling, and so that when the people see it, they think, oh yeah, do you know what, this is where the money's been spent. And like anything, whether you're buying, whether you're working with someone, likability is always a massive part. So I will pass back to Dom. That's a relatively brief overview of how I've looked at the process, and we'll answer some questions.
Perfect, thanks, Jeff. Well, we've got about 15 minutes or so we've got a few pre-submitted ones that we want to get through. I know there's a couple that have come in on the Q&A function. Just for anybody who's going to ask some questions, pop them in the Q&A function and we'll get them in. If anybody's got any questions around physiology or any specific systems, we do have other webinars on that which we can share with you at the end when we post things out following the session. But Jeff, we obviously, one of the things is about diagnostic ultrasound, using it with focused shockwave. From people who don't know, I'm sports therapy by background. I don't scan. I've been using focused shockwave for 3.5 years, so you don't have to use it. I'd say relatively successful with it. There are certain indications though where I'd be like, probably want to scan, or if like you say, something isn't reacting how you think it would. Where it might be you're thinking it's a patella tendinopathy, but actually it's a bursitis, and when something's not really going down the way you think it would. But for those who are looking at, like, I can't really say which one's the better investment. So somebody's asked, what is the better investment, ultrasound or shockwave? But I suppose it depends on what they're looking at.
Yeah, I think again, it's what's your drive. You know, if you want to become an MSK sonographer, then obviously you need to go down that route, which does take time, and it's a process. It's not a quick 6 months. I can be trained and I can scan and I can charge for my scan ability. Whereas the shockwave, immediate. You know, you can buy a product, you can get trained. It's within our scope of practice as long as we're competent in using it, and we know the contraindications and the precautions. And like Dom said, you don't need ultrasound. You can use it very, very effectively. It's just those few where maybe they don't get better, but the majority of things will. given the right diagnostic, which again, if everyone's got very good clinical skills, you're not going to be far off.
Yeah. I think so. Some of those ones, like if you're thinking calcific tendon, particularly in shoulder, that's one where I might be like, I want to sketch, I want to know the depth of it so I can hit it, because the evidence is if you can hit it directly, you're going to get reabsorption rates a lot better. Same with maybe some of the deeper ones, your hamstring tendons, that kind of thing. Or if you're looking at like hip joint, you might want to get a gauge on depth. And even just the extent of the injury, if you're thinking, is it a partial thickness tear or is it tendinopathy? There's some things you might need to rule out before. In terms of ultrasound and how you use it, do you use that as a tool, as an outcome measure to show to your patients how they're progressing, or are you just looking at, is it just diagnostic?
So clinically, and this is the same way if you've got a tendon or muscle injury, you don't need to rescan. We're doing it for our own purpose. And I always say that to patients, I was like, look, I might want to rescan this in 6 weeks because I want to look at, healing phase, is there good scar formation? But ultimately you're going by function. So if someone's pain-free and can do a single leg hop, and all these other outcome measures for an Achilles, and they can run, and then you don't need to rescan it, obviously. But I kind of like to see, has the Shockwave done what I expect it to? So I always measure tendons, so I can measure the diameter in cross section or in long section. So I can go, well, this is a normal tendon and this is your tendon. So we know a normal Achilles is about 0.4 of a centimeter in diameter from back to front. And that gives you a good indication of the level of tendinopathy. If it's like 0.6 or if it's 1.6, you can manage that patient far better. So, and again, for the calcific deposits like Achilles, I rescan them because I want to know if that calcific deposit's changed. Even if they go, I'm pain-free now, I still want to know, has it done what I've told them it will do? But that's fully for my own ego, I suppose.
I guess you wouldn't hang your hat on it though, because I know it's like some radiographic changes can take months before they
absolutely change. So all about function, all about pain response. Ultimately, what it looks like on scan doesn't really matter.
So still on the topic of the diagnostic ultrasound, I know there's a couple of questions that have come in. So how long does it take to become truly proficient in musculoskeletal ultrasound?
I think the quality of the courses is key. I think if you're going to do it, you kind of want to plan it like you want to plan timeline. You could start off just with a weekend course and see how you get on with it and decide whether that's something for you or not. Some people just don't get pro position and being able to look at it on the screen, but it is a process. You've got to learn it, like riding a bike, but you've got to learn it. So I would always say, start with a basic course, get a grasp of what it's like. Do you pick it up quickly? Do you not? You need a PGC. You need to be competent at an academic level, not just practically, because we're healthcare professionals as far as I go from a physio perspective. So we have to have that governance of duty of care and quality of knowledge. But obviously alongside that, you need to buffer that up with, a mentor, other courses. You're always learning. I mean, I'm 8 or 10 years in, and I wouldn't say I'm A1, maybe A3. So there's things that I know because I don't scan them every day that I'm not as confident in. I can still scan it and be pretty good, but do a hamstring. I'll do 10 Achilles a week, that do a shoulder every day. They're bread and butter for me. So it depends on what you see in your clinic. You might just see shoulders, but you can become proficient at scanning just shoulders. If you're a shoulder surgeon, they will only do shoulders. So your competency level can be dictated by what you'll see, in essence. But I mean, I think you've got to give yourself a good couple of years minimum. And I've scanned every day for 8 years, and I'm only just starting to charge.
I think just to add to that, like we get a lot of people who are very interested in starting MSK ultrasound and interested in buying a system, and many haven't been on a course yet. And we're just like, right, get yourself onto one of these 1 or 2 day courses and just figure out if it's for you. before you even consider spending however much on an ultrasound system. And at least you can gauge then whether it's like, you can go and speak to those educators and they can give you their experience as well. Because we see some people that pick it up almost instantly, and some people that it does take a little bit longer. But obviously on the focused shockwave side of things, you already touched on it. It's just pretty much within half a day of training that we can do, and another sport you can pretty much pick it up and carry on. And I just want to touch on, obviously I know this is about the business side of things, Jeff, as well. We talked about return on investment. Obviously you're looking at financial return on investment. The return on investment for diagnostic ultrasound focused shockwave can be slightly different, and ROI can be different things. It can be financial, it can be improving clinical outcomes and excellence, reducing patient contact time. There's a multitude of things. When you're looking at finance and how to build that profit, we talk about increasing income per hour, but then it's actually looking at, and I think you touched on it, about the expenditure of how much that system is to buy and how much it is to run. Like, what's your advice to those who are looking at it? Might be take Shockwave for example, but looking at equipment, what are the things that you mainly look at, and how do you quantify and ultimately make that decision to reduce the risk?
Yeah, so I mean, risk really is how much you want to spend, and if you can pay for it outright, then the risk is low because you bought the product, you've got no finance on it. If you don't sell any, you've got the product still. So it's, risk is all about what happens if you don't use it. If you've got a monthly repayment system in place, then that's drawing money out of your profit. Or if your profit line is quite low, then it's eating into, and it could be a negative as well. So I think it's, even if you get something on finance, it can be quite quick and easy. If you've got to sell one package a month, but that package pays for your finance, then for me the risk is quite low. So I also got worst case scenario. What is the worst case scenario? And if you can answer that question, you can minimize your risks significantly.
Yeah. I think with, one of the things that we are always discussing with people is that, like you've already touched on it, the radial versus focus debate. Obviously, there's the debate on the physiology and the working principles, but just from a business perspective, price perspective, elephant in the room is radial's cheaper than focused.
Yeah.
More affordable. We'll say more affordable than focused from a price perspective. And some of the things that we work on internally is price versus value. And quite often the price is the big thing in bright lights that you almost just can't take your eyes off. What is the value that you see? Like, you chose focused shockwave. So what was the difference for you? It's going to be different for different people, because people got different budgets, different demographics. But for those who are in a very similar situation, considering radial focused, what was the deciding factors?
So the big thing with radial is it's pro-inflammatory. It's there to aggravate the tissue. We know from research that most of the energy delivered by radial is absorbed by the skin. So the depth of your target tissue is quite low. Whereas with the piezo wave that I've got, I can go up to 6 centimeters in depth, or shallower based on the spacers. But with radial, you've got a fixed depth. And again, like a lot of therapists, the skin absorbs a lot of the energy. With the focus, because of how it's delivered, the energy source at the point of contact, the energy there is what you expect it to be delivered at. So you can really target very specifically. I think I've got a picture on my last slide which shows the probe, and the energy delivery is about the size of a seed, and then you have reducing levels of energy around that, bit like a dartboard. So if you can guarantee you're getting X amount of energy to that point, then you can pretty much guarantee that you're going to have a much better effect. Radial is also quite painful, so a lot of people I see have had radial, and some may have had good response, but again, we see a lot who haven't, and I think that's down to, again, maybe diagnostic, maybe depth of treatment, maybe actually the fact that you know, if I got an instrument and just did scraping on that tendon, am I going to get the same physiological response to the radial? Possibly. With focus, I can't replicate the physiology that produces. And that was why I chose focus. I want the best machine. Okay, it costs more, but I can pretty much guarantee the outcome of that patient when I see them. Radial, you know, may or may not.
The thing is, it's bias coming from our perspective. Obviously, we predominantly do focused at the moment, but it's that you've got to look at that, whether it's what that initial outlay is. You've got the initial outlay, but then you've got the cost of the lifetime of the device. And if you go from radial and want to move to focused, you're probably spending, you're spending more than if you went straight in with one. Although we know that you might only have a certain amount at a period of time. So it is obviously situation dependent.
And I did that as well. We had that conversation, didn't we, about, do I go radial first? Because it was a new thing for me, and I was a bit like, do I want to spend more with a focus? But then once you look at it and you go, well, what's the reason you want it? Are you going to charge for it? Are you not going to charge for it? What's the clinical response? And then I quickly shifted.
So I think on that, there's been a couple of questions of like, you've already touched on it a little bit anyways, how you introduce it to your business first and foremost, and obviously with the training session, which is all included in the costs of it, to get your team on board. It's a big part, is getting your team buy-in. But then from the patient perspective, how did you introduce it to them and continue to introduce to them to get the buy-in? Because ultimately that's what you need. They're going to be paying for it. So yeah. What methods did you have to introduce it to the market, to your market?
So I think for us, it was always you assess, you treat, and if someone's getting better, fantastic. I always put anything out there as if money was no object, so you're not influenced by that as a reason to do something or not, what would be best practice? So you can drop that seed at any point. Could be session 1, could be session 3, and you can say, look, we can do this, or we can do this with this. So it's very much about a shared decision with the patient. So educate them. I've done leaflets. So if I've had a chat with them about it, I'll give them a leaflet so they can go away and think about it. And then I always say, look, if in 3 sessions we're not at a loading point, then you might want to consider. And if you do fancy considering it, I'll give you a free session and you can test before you buy. And I think that was always important for me. If you're paying X amount of money, if you can test the goods and you go, well, that was good, then your buy-in's there straight away. Otherwise, there's always that little bit of, is it going to work? I don't know. They're telling me it will, but I don't know. So fish hook, always about the fish hook.
Yeah. And it's something I want to really enforce as well, because and one of the points that you made was about the running costs as well, and actually factoring those into your equation of the returns as well. I think it's something that you can get clouded with the initial price. Something might appear cheaper to start off with, and we've looked at distributing new bits of equipment recently where the actual purchase price is pretty decent. You think that's great, and then the ongoing costs, you go, oh, that's not great. And it's one of those where I think, if you're looking at equipment, whether that's Shockwave, laser, whatever other bits of kit, find out what servicing there is, find out how long these things are going to last, find out what wearable consumable components there are, so you can factor those things in. I think it's a massive thing that sometimes, not all the time, gets overlooked, and does have a big impact on the income that you generate. And the last question before we go, Jeff, is one of the questions that came in. Is you currently using Focus Shockwave and you're predominantly MSK? Have you ever looked at any additional applications outside of MSK, so like your men's health, pelvic pain, anything like that?
I think it's what floats your boat. I'm not particularly motivated by men's health. I have a friend who is, so he uses this for men's health with fantastic results. So whether that's the usual man issues we won't go into, but people who have those problems, there's very limited people out there. So as a marketplace, he has tried to say, look, why don't you get involved? It's lucrative in terms of there aren't many people doing it, and you can charge a standard fee, but the results are great as well. So similar to Achilles, knees, whatever it is you want to treat, if you can guarantee an element of strong success, then that's a huge selling point. And then again, if you're doing something where your USP is quite unique in your area and no one else does, well, there's your driving train, there's your advertising pitch. No one else does this, and you'll be surprised how many people come out of the woodwork who maybe have just accepted they've got a problem and it could be treated. So there are other options. There's, again, Dom, you'll know probably more about the other alternative uses, and that may be something we look into at a later date. But we're probably a year into now having Focus, so it's paid itself off, which is fantastic. And it may be we want to look at diversifying it.
How long did that take to pay it off, out of interest?
Well, we had a cracking few months to start with, because everyone was on board and everyone was like, yeah, I want to use it, So I reckon 6-7 months, which is far better.
Yeah.
But once you start selling packages, maybe 10 in a month, 15 in a month, it soon starts to add up. So it's, set yourself a reasonable target that's achievable, and if you overachieve, amazing. If you underachieve, your target's probably too aggressive. So always go on what you think you could do, not what you want to do.
Yeah. Jeff, we're going to have to finish it there because we can go about this all night, I think. But hopefully for those who have been on, has given you some food for thought, and we've answered some of your questions just about the business side of things and how to implement these technologies, specifically ultrasound and focus shockwave, but it might be applicable to some other things that you do as well. You want to flick to the next slide? Is that right, Jeff, please? So yeah, just to close, thank you all very much for joining and your contributions in the chat as well, and for those who pre-submitted their questions. Jeff, thank you very much for taking your time out to deliver this and prepare this for everybody and really share your experience. Following this, you will receive an follow-up email for all the attendees, which will have a survey and a link to this recording. We'd appreciate your feedback, any suggestions for future webinars. We might be able to do a follow-up with this, more discussion-based maybe, as well. If you'd like to register for the Physical Academy, we'll send a link there as well, so you can have a look at the past webinars, any things that we've done around diagnostic ultrasound and focus shockwave as well. There's lots of resource there for you. If you do want to find out more about how these products can fit into your clinic, give us a shout. We are here as a consultancy service as well. So if you just want to find out a little bit more about what other products are on the market, how our products might be able to help, advice is always free. So we can always speak to you about what could work for you in your clinic. If you've got anything else, you feel free to contact us at info@physiquip.com. Otherwise, thanks again, Jeff. Thanks again, everybody, for joining us. And thanks to Katie as well, who's been in the background doing all the admin side of things. We hope you enjoyed the session, and we hope to see you all soon.
Cheers, Dom. Catch up soon.
See ya. Thanks.
Bye-bye.